We are going to talk about anti-hypertensive drugs. First, let's do a little overview of how the body comes up with the blood pressure. So blood pressure is equal to the cardiac output times systemic vascular resistance. So our cardiac output, that's the volume of blood pumped out of the left ventricle every minute. The systemic vascular resistance, this is the resistance to the blood coming out of that left ventricle. Okay? So cardiac output is equal to the heart rate times the stroke volume. Our cardiac output is about 5 liters per minute. So that's how much blood is circulating through our system per minute. Your heart rate, you know what that is, the stroke volume. It is approximately 70 milliliters. It is the amount of blood that's pumped out of the ventricle with each beat. Okay? Hypertension is a persistent increase in blood pressure. According to Lewis, chapter 32, it says you need 2 separate blood pressures, 2 minutes apart, and alternate arms to be diagnosed with high blood pressure. So if you're 60 years or older, a systemic blood pressure greater than 150 or a diastolic blood pressure greater than 90 is considered hypertension. If you're less than 60 years old and you have chronic kidney disease or diabetes with a systolic blood pressure above 140 is considered hypertension, or a diastolic blood pressure greater than 90 is considered high blood pressure. So how is our blood pressure regulated? It is by the sympathetic nervous system. Our sympathetic nervous system detects a decrease in our blood pressure. We want to maintain our blood pressure because we have to have a certain amount of blood pressure to be able to perfuse all our organs adequately. Okay, so the sympathetic nervous system notices a drop in our blood pressure, and what it will do is it will increase the heart rate, because if we increase our heart rate, remember that cardiac output is equal to heart rate times stroke volume, right? So if we can increase our heart rate, that means we're going to increase our cardiac output, okay? If we increase our force of contractility, that's the contractility of the heart, that's going to increase our stroke volume, which is then going to increase our cardiac output, which also then increases our blood pressure. With vasoconstriction, that increases our systemic vascular resistance, okay? When we increase our systemic vascular resistance, that increases our blood pressure, okay? And then lastly, the increase in release of renin. If we increase the release of renin from the kidney, that will increase our intravascular volume, which then will increase our blood pressure, okay? So why is it so important to keep our blood pressure within normal limits? Well, because it will, if you have high blood pressure, it will increase your risk of cardiovascular disease. It will increase your risk of coronary artery disease, which we're talking about heart attacks and strokes. It can cause damage to end organs like your heart, your kidney, your brain, and your eyes. So if you have high blood pressure going to your heart, it causes coronary artery disease, okay? If you have too high blood pressure going to your kidneys, it can do damage to your kidneys, which will cause inflammation and scarring in your kidneys and will decrease your glomerular filtration rate in your kidneys. In your brain, it can cause cerebral vascular disease. And with your eyes, it can cause hypertensive retinopathy, which is narrowing of vessels in the eye. So it's super important that we control our blood pressure so that we can keep these organs healthy and functioning properly. So how do we treat hypertension? Each of these drugs we may use in combination or we may use them alone. Basically, all these drugs are going to work on those mechanisms that work to maintain our blood pressure. Okay, so how do diuretics help hypertension? Well, diuretics are going to decrease our intravascular volume, right? So if we decrease our intravascular volume, we're going to decrease our blood pressure. Okay. With adrenergic drugs, these are beta blockers. Beta blockers are going to decrease our heart rate, which you talked about decreased our blood pressure. They're going to decrease the contractility of the heart. They're also going to decrease renin secretion. So if we decrease renin secretion, that's also going to result in a decrease in intravascular fluid volume, right? Alpha-1 blockers, they cause vasodilation. If you vasodilate the vessels, then you're going to have a decrease in blood pressure. Alpha-1 blockers also cause relaxation of the urethra, which is used for benign prostatic hyperplasia. Alpha-2 agonists, they are going to stimulate the suppression of the sympathetic nervous system. This is something our body has naturally, so our sympathetic nervous system doesn't go out of control, right? Vasodilators will directly decrease blood pressure. Our ACE inhibitors are going to block, if you remember what ACE does, ACE, angiotensin converting enzymes, they convert angiotensin 1 into angiotensin 2. And so if we block ACE, we're going to block the conversion of angiotensin 1 into angiotensin 2. And angiotensin 2 is the one that does all that damage of causing vasoconstriction and aldosterone secretion, okay? Your angiotensin receptor blockers, your ARBs, these block the action of angiotensin 2. So ACE inhibitors and ARBs are going to have very similar mechanisms of action. Your calcium channel blockers, they cause vasodilation. Decreased myocardial contraction. And decrease the heart rate because they work on smooth muscle and cardiac muscle, just all muscles. So the smooth muscles that's around the vessels is going to relax and cause vasodilation. The cardiac muscle is going to relax it, decrease the myocardial contraction, and then also cause the decrease in heart rate. So your direct renin inhibitors, well, you're going to decrease the production of angiotensin 1. Okay, that's a good overview. So now let's get more specific. We're talking about adrenergic drugs, alpha-adrenergic blockers. They all end in osin, okay? They use these for hypertension and benign prostatic hyperplasia. So what they cause is vasodilation. There's a relaxation of the smooth muscle at the prostate and the bladder neck. Adverse effects, the first dose can cause orthostatic hypotension, so something we need to make sure our patients are aware of. Contraindications, if they have angina or renal insufficiency, because it does affect the GU system. Interactions, other antihypertensives are going to have a increased antihypertensive effect if you add them together. Nursing considerations, you want to monitor their blood pressure for 2 to 6 hours after the initiation of treatment. Make sure it's doing okay. Patient teaching, they need to report any new symptoms. It may take 4 to 6 weeks to achieve full therapeutic response. They should take their first dose at night, so because it can cause syncope and severe hypotension, it tends to be better tolerated if the first dose is at night. They need to avoid activity requiring alertness for the first 24 hours until the patient really gets used to the effects of the medication. Instruct patients to lie down if any signs of hypotension so that they don't fall and hurt themselves. Safety measures to minimize effects of orthostatic hypotension, which would be like sitting up. When they're first getting up, they need to sit up for a little bit, then they stand. They need to monitor their blood pressure and their heart rate. So adrenergic drugs, alpha agonists, they can be PO, epidural, or patches. Mechanism of action, it increases the suppression of the sympathetic nervous system. So it's agonist, so it's stimulating the effect of the suppression of the sympathetic nervous system. So adverse effects, causes drowsiness and sedation. A dry mouth can cause rebound hypertension. Contraindications, bleeding disorders or anticoagulants if they're breastfeeding. Interactions, other antihypertensives are going to have an additive antihypertensive effect. And patient teaching about patch placement. That means they need to rotate sites. They don't need to put the patch on hairy areas. They should remove the old patch, clean and dry the area before putting on a new one. And they need to not rub the area before putting on a new patch. And they should avoid alcohol because alcohol is going to decrease their blood pressure as well. Now I talk about beta blockers. These end in LOL. The mechanism of action depends on what kind of beta blocker it is. We have cardioselective, which means it works on the beta 2s receptors. Non-selective means it works on beta 1 and beta 2. So you have beta 1 cells in your system and you have beta 2 cells. So you have beta 1s in your heart, because you have one heart, and you have beta 2s, that's in your lungs, okay? So if they're cardioselective, they only work, it means they just work on your beta 1, okay, which is your heart, okay? If it's non-selective, it's going to work on beta 1 and beta 2, so that means it's going to do heart and lung activity, which is important when we think about adverse effects. So if it's cardioselective, so it's specific to just the beta 1s, then it's going to decrease the heart rate, it's going to decrease the contractility of the heart, it's going to decrease the rate of conduction through the AV node, which is how it decreases the heart rate. It decreases renin secretion, okay? Your non-selective beta blockers, these have all the mechanism of action that the cardioselective have, but it's also going to have bronchoconstriction, because remember, this is beta 1 and beta 2 because it's non-selective, so it's going to affect the lungs, so it can cause bronchoconstriction. You have some beta blockers that are alpha and beta blockers, they're both, and so they have all the non-selective mechanism of actions and also cause vasodilation, okay? So most of your beta blockers are given, your beta blockers are given to all patients in acute stages of a myocardial infarction, because following a myocardial infarction, there are high levels of epi and norepi floating around in the blood, and the beta blockers help counteract the effects of the epi and norepi. And so that's why they're given to all patients in acute stages of myocardial infarction. So your adverse effects for your cardioselective, it's going to be all cardiac related. So you have bradycardia, decreased cardiac output. It can cause AV block because it does slow down that conduction. Orthostatic hypotension because you're decreasing your blood pressure. And it can cause rebound myocardial excitation, meaning that if you, it can cause palpitations. Okay? So non-selective are going to have all the cardioselective adverse effects along with bronchoconstriction, and it can cause hypo or hyperglycemia. Now, the reason for this is that it is a beta blocker. Okay, remember that when the pancreas has beta cells, the beta cells are the ones that secrete insulin. So if we don't secrete, if it's a beta blocker, it could block the secretion of insulin. It could block the action of the beta pancreatic cells. So if you decrease the action of the beta cells in the pancreas, it's going to decrease insulin. If you decrease the insulin production or secretion, then it's going to cause an increase in glucose in your system. Now, how it can cause hypoglycemia is that in patients that have diabetes, they may not recognize their signs and symptoms of hypoglycemia because beta blockers will mask the signs and symptoms of hypoglycemia. So patients that are diabetic really need to watch, that are on beta blockers really need to watch their glucose levels very well. Okay. Now your alpha and beta blockers, those are going to have the same adverse effects as your non-selective. So your contraindications for your cardioselective, if they already have AV block, if they already have sinus brady, if they already have hypotension, you do want to use caution in patients that have asthma, diabetes, and depression, because even though they're beta-1 selective, they can sometimes have some beta-2 effects. Your non-selective contraindications is all the cardioselective contraindications. You're not just caution, but it's contraindicated for asthma patients, for bronchospasm patients, and patients who have heart failure. Your alpha and your beta blockers are going to have the non-selective contraindications. So interactions, other antihypertensives, so they're going to have an additive central nervous system depression with alcohol, benzodiazepines, and opioids. So other medications that cause decrease in blood pressure, it's going to have an additive effect. Okay, so nursing considerations, you want the heart rate. If the heart rate is below 50 per minute, you want to hold the medication and notify the provider. Orthostatic hypotension precautions like dangling and stuff like that. Diabetic patients, we need to monitor those glucose levels closely because of that risk for hypo and hyperglycemia. Okay, and then monitor breath sounds because it can cause bronchospasms, right, and respiratory rate. Patient teaching, make sure they administer it as prescribed. They don't need to DC without consulting their provider. In fact, there's a black box warning that says that it must be weaned over 1 to 2 weeks. They cannot abruptly stop taking it. They do not need to chew or crush the extended release tabs. They need to monitor their heart rate and blood pressure at home every day. They should take it with food and avoid sudden changes in position because of the potential for orthostatic hypotension. This just keeps them safe. They need to report any edema because how are they going to know they have edema? They should be doing daily weights. And if they do daily weights, they should, okay, so edema, so daily weights. That's going to help them know if they have any edema. They need to report a weight gain of 2 pounds in 24 hours or 5 pounds in a week. Okay. They need to report any constipation, dizziness, hypotension, and sexual dysfunction. They need to know that it may cause sexual dysfunction, and if it does, then they need to just still take their medication and then notify their provider. Their provider can change that medication. If you warn them not to discontinue their medication because of the sexual dysfunction, because otherwise they're going to say, oh, it causes this, I'm going to just stop taking it. And they really need to know that it might potentially happen and that we can just change the medication if it does, and not to abruptly stop the medication because of that side effect. So ACE inhibitors, remember, prevents angiotensin 1 from turning into angiotensin 2. So it's going to inhibit all the actions of angiotensin 2, okay? ACE inhibitors are often the first line of treatment for heart failure and hypertension. The mechanism of action, we already talked about, inhibits the angiotensin converting enzyme, which causes so it's going to cause vasodilation and increased excretion of water and sodium in the kidneys, and it's going to have the kidneys keep potassium. This will decrease the vascular volume, which will decrease the systemic vascular resistance. So let's put this, so it's going to decrease the intravascular volume, which then results in a decrease in systemic vascular resistance, which is going to decrease our blood pressure. Okay? It also has a bit of protective effect on the kidneys because you're decreasing the pressure in the kidneys. Okay? Adverse effects, the first dose, orthostatic hypotension, so it can cause that. Dry, non-productive cough. This is super aggravating to patients. So if they get it, they may stop taking the medication. So patients need to know, okay, they may get a dry, non-productive cough. If they do and it really aggravates them, then we can switch them to a different medication. It can cause hyperkalemia because we're telling the kidneys to keep potassium now, right? We're retaining potassium. So we need to monitor the potassium levels. It can cause a rash. It can cause altered taste or a loss of taste. They can last 2 to 3 months after you stop the medication. It can cause angioedema, which is swelling of the face, the tongue, the larynx, the abdomen, the arms, legs. It's basically like an allergic reaction, which can progress into anaphylaxis. It can cause neutropenia, so we need to monitor the white blood cells. So our contraindications, if they have renal stenosis or one kidney, it would be contraindicated because the ACE inhibitors manipulate the kidneys, right? What the kidneys do. We need to closely monitor the patients with infection because it can cause leukopenia. Interactions, diuretics, other antihypertensive meds is going to cause increased antihypertensive activity. Potassium supplements and or potassium-sparing diuretics will further increase potassium levels, so we need to be aware of that. Lithium, it may cause a lithium toxicity. Patients that are on lithium for, say, bipolar disorder. NSAIDs, these may increase the risk for acute renal failure because NSAIDs also will decrease perfusion to the kidneys. So it can cause damage if you have ACE inhibitors and use NSAIDs at the same time. So nursing considerations, blood pressure is monitored every 2 hours after the first dose. Orthostatic hypotension precautions, change position slowly. We want to monitor potassium levels, monitor white blood count because the potential for hyperkalemia and neutropenia. We need to monitor for signs and symptoms of hyperkalemia. With patient teaching, avoid sudden changes in position because of the orthostatic hypotension. Avoid activities that require alertness until the effects are known, until they get used to how you're going to react to the medication. Report any signs of angioedema immediately because it can turn into anaphylaxis. Avoid salt substitutes that contain potassium because it's giving you a little potassium supplement and you're already at risk for hyperkalemia. You do not want to abruptly stop this medication. Remember the black box warning. Oh, this one doesn't have a black box warning. Never mind. And it may take 2 to 3 months for changes in the taste to return to normal if they have that impaired taste. Okay. They also need to make sure they report any palpitations, dizziness, nausea, dyspnea, stuff like that. So angiotensin II receptor blockers, these are better tolerated than ACE inhibitors, but ACE inhibitors are still the first ones that are used. We use them after a heart attack to decrease mortality. Mechanism of action, it blocks the action of angiotensin II. These are your ARBs. Causes vasodilation, so relaxation of the smooth muscles surrounding the vessels. Causes increased excretion of water and sodium and retaining potassium in the kidneys because of the suppression of the adrenal gland. So just like we had with our ACE inhibitors. Adverse effects are very similar. The biggest thing that's missing here is that there's no dry cough with ARBs. So that's the benefit with the ARBs over ACE inhibitors. The hyperkalemia that occurs with ARBs, it's less often than happens with ACE inhibitors, so it's not quite as bad as it is with ACE inhibitors. Contraindications would be pregnancy, renal stenosis, one kidney, and then be used cautiously in patients who had angioedema with ACE inhibitors because it could also happen with ARBs. Interactions, other antihypertensive drugs, lithium, can cause lithium toxicity. Nursing considerations, we want to monitor for the angioedema, monitor blood pressure, monitor our potassium levels. We want to teach the patient to use contraceptions. Avoid sudden changes in position because of the risk for orthostatic hypotension. Avoid activities that require alertness until the effects are known. And then report any dyspnea, dizziness, excessive fatigue. Now we're moving on to calcium channel blockers. So calcium is needed for muscle contraction. Okay, so our mechanism of action, there are two types. You have the dihydropyridine calcium channel blockers and the non-dihydropyridine calcium channel blockers. Okay, the ones that are dihydropyridine calcium channel blockers, they block the entry of calcium into the cell of blood vessels. They all end in pene. You may notice, look at all these penes. So when you see a pene, know it's an ACE inhibitor. I'm sorry, a calcium channel blocker. So since it blocks the entry of calcium into the cell of a blood vessel, it's going to decrease the smooth muscle contraction of the arteries, which results in vasodilation. Your non-dihydropyridine calcium channel blockers, they block the entry of calcium into the cells of the heart and the blood vessels. So because it works on the heart and the blood vessels, you're going to have this slowing conduction through the AV node, decreasing myocardial contraction, vasodilation because it decreases that smooth muscle contraction of the vessel, and then it decreases the heart rate. So your non-dihydropyridine, because it acts on the heart muscle as well, you're going to have the heart effects of the calcium channel blockers. So your adverse effects with the dihydropyridine calcium channel blockers, your PENS, reflexive tachycardia, acute toxicity is a potential, orthostatic hypotension, peripheral edema. Your non-dihydropyridine calcium channel blockers, you can have orthostatic hypotension, peripheral edema, constipation, bradycardia, heart failure, can cause dysrhythmias, and acute toxicity. So they have some similar ones, but some ones that are just specific to the non-dihydropyridine calcium channel blockers because they have that additive heart effect. So your contraindications, basically calcium channel blockers may make heart failure worse. Heart failure is when your heart is not pumping well, so the blood is not circulating well, okay? So your dihydropyridine calcium channel blockers, your PENS, can cause, if their contraindication would be cardiogenic shock. With shock, you have decreased perfusion, so this can make that decreased perfusion even worse. So if they already have cardiogenic shock, you don't want to use calcium channel blockers. You want to use caution with calcium channel blockers if they have a heart attack, AV block, hypotension, angina, or aortic stenosis. Your non-dihydropyridine calcium channel blockers, contraindicated if they have hypotension, if they have heart block because they can slow conduction, digoxin toxicity, severe heart failure, and lactation. So your interactions would be beta blockers with your non-dihydropyridine calcium channel blockers. Interactions with digoxin, we talked about, can cause digoxin toxicity. Interaction with beta blockers and grapefruit juice. Grapefruit juice actually decreases the metabolism of calcium channel blockers, which can increase the amount of drug in the blood and cause more adverse effects. Nursing considerations, you want to monitor for signs of toxicity, monitor for edema, monitor heart rate and blood pressure before and during therapy. Patient teaching, they should weigh themselves daily to monitor for edema, monitor blood pressure every day, change positions slowly because of that orthostatic hypotension. They need to report any new symptoms. The non-dihydropyridine calcium channel blockers, they should increase their fluid and fiber intake because of the potential for constipation. They need to know the signs and symptoms of suppression of cardiac function. Diuretics, we're going to talk a lot about diuretics in another lecture, so we're just going to skim over these. So the mechanism of action of diuretics is to decrease the vascular fluid volume. Effects on potassium, loop, and thiazide diuretics can cause hypokalemia. Potassium-sparing diuretics can cause hyperkalemia. Thiazide diuretics are most commonly used for hypertension. Vasodilators, these are used for hypertensive emergencies. They're stronger than nitroglycerin, which we'll talk about when we talk about angina medications. Mechanism of action, it causes major vasodilation. You have arterial and venous smooth muscle relaxation, which causes a severe drop in blood pressure. The adverse effects are tachycardia, because the sympathetic nervous system kicks in, headache, dizziness, nausea, vomiting, loss of appetite. It can cause cyanide poisoning and thiocyanate toxicity. It can cause excessive hypotension, EKG changes, contraindications, basically any situation where you have a decreased perfusion, if you have bleeding, so like hypotension or head injury, etc., is going to be contraindicated. So heart failure and AV shunt are contraindicated for these. Now the reason that cyanide poisoning is a potential adverse effect is that the breakdown of nitropyrroside, when it's metabolized, cyanide ions are a byproduct of it. So those cyanide ions can build up if you have issues with your kidneys, if your kidneys don't get rid of them effectively, and so you can have cyanide poisoning with this. So interactions, you don't want to infuse it with any other medication. Nursing considerations, you want to monitor their blood pressure because it can cause such a severe drop in blood pressure. You want to protect the IV bag and tubing from light. Monitor for signs and symptoms of cyanide toxicity. Discard the medication after 24 hours. You want to monitor vital signs and EKG continuously because the vasodilators can cause EKG changes. You administer it very slowly. You don't want to infuse it or the maximum dose longer than 10 minutes because of the massive decrease blood pressure effects. The patient teaching, just report any new symptoms. Although if they need this, they're going to be in pretty bad shape. So assessment and nursing considerations just overall. So you want to monitor their heart rate and apical heart rate, okay? You want to monitor their blood pressure, their respiratory rate, their pulse ox. IV beta blockers and calcium channel blockers require cardiac monitoring because they affect the heart. So they would need to be on a cardiac monitor if you have IV beta blockers or calcium channel blockers. Labs you would need to look at: sodium, potassium, and calcium. Renal and hepatic function, because we need many of them. The prodrug needs good hepatic function in order to metabolize into an effective drug. ARBs with caution with renal dysfunction. You want to monitor CBC, platelet, CRP, which is kidney function, and lipids. You want to monitor for end organ damage. So your eyes, you're looking for hypertension, retinopathy. With your heart, you're checking out perfusion. So capillary fill and pulses are going to tell you how well you're perfusing. With renal, you're going to know it's perfusing effectively if you have good urinary output. With brain perfusion, we're going to be checking their mental status, okay? Chronic illnesses, you want to monitor for those. Breath sounds, respiratory illness, because remember the beta blockers, the non-selective ones, can make these worse. And ACE inhibitors can cause a cough. Ongoing assessment, blood pressure, weights, because we're checking for edema. Diet and exercise. Ask about sexual dysfunction, especially with those beta blockers. Evaluation, so did it work? Is their problem getting better? So do they have an absence of chest pain or absence of dysrhythmias? Is their blood pressure within normal limits? Control of heart failure manifestations. So is the reason they were on the drug, is it working? Is it making it better? That's how we're going to evaluate whether or not the drug is effective. So with patient education, we're going to teach the importance of compliance. They need to take the medication exactly as it's prescribed. It's not I don't feel bad, so I'm not going to take the medication. They need to understand that they don't feel bad because they are taking the medication, so that they're directly related. They need to understand the risk of abrupt stopping the medication, that it increases their risk of cardiovascular disease. We'll put that. Or a CVA. Caution with activities that cause alertness until they're used to the effects of the medication. They need to report systolic blood pressure of 90 or less, or heart rate less than 60. That's important to know. It will take several weeks for the full therapeutic effects to happen. They need to understand that there's a potential for sexual dysfunction, and if they do experience that, they need to notify their provider, still keeping their medication, taking their medication until their provider can change them to something else. Periodic eye exams every 6 months just to check for that hypertensive retinopathy. They need to understand that this is lifelong therapy. Lab tests, they need to follow up appointments are important and very necessary to make sure that the medications are effective. Safety, they need to avoid alcohol, because excessive heat and excessive exercise, because these may decrease blood pressure and cause vasodilation. They need to avoid smoking because smoking increases blood pressure. So these increase blood pressure and these decrease blood pressure. They need to wear a medication bracelet. They need to be careful changing positions. They need to change positions slowly because of the orthostatic hypotension risk. They need to report weight gain, an increase in 2 pounds in 24 hours or an increase in 5 pounds in a week or more because of the potential for edema. And then they need to report any new symptoms.